Thank you, Dr. Collishman. Where's the, where are we? Yep. Great. Well, thank you. Boa tarde. Thank you, everyone, for staying to the end for me. I sort of the last lonely one here, but I hope I will entertain you nonetheless. I want to mention two things. First of all, this slide, to answer the question I've gotten on this slide before is whether it's the sunset or is it the dawn? And I suppose that depends on whether you are an optimist or a pessimist or something. But I actually think that this may be a good slide for my talk because as I will explain, as we head into the 1990 world in the near future, the end of the epidemic is going to look a lot like the beginning of the epidemic. And one of the main points that I wish to communicate today is that acute HIV infection, which drove the beginning of the epidemic, is likely to drive ongoing transmission that occurs at the end of the epidemic after we achieve 90-90-90. So I think that what we're talking about today is a strategy not just to get us to 90-90-90, but it is an important, very important thing to think about for what we do once we are there, which I think many of us have not started to think about. The second thing I want to say, not about the picture, but is about Esper. Yesterday, I was congratulated for breaking the world record for the longest question. I always say that everything I am, I learned from Esper. So if my talk is really bad, you can blame Esper. Anyway. So, I'm going to talk about strategies for targeting acute and early HIV infection. And I will argue that the distinction between acute and early or recent HIV infection, those terms, is entirely arbitrary. It has to do with whether antibodies are at a level that's positive on some assay. And I think that I like to think of acute and early infection as a spectrum of disease rather than two separate things. The rationale I'm going to talk briefly about. The public health importance of acute infection is well known. And there are some also emerging data on individual benefits of emergency immediate treatment during acute infection. In particular, I'd like to share with you some brand new data that was just presented at CROI about the potential protective effect of immediate treatment on the nervous system. Then I'm going to briefly cover strategies for identifying acute and early HIV infection, and finally talk about same-day treatment initiation, which is becoming an important feature of managing this phase of disease. So the first question is why? Why am I so interested in acute infection? Why is Esper so interested in acute infection? Aside from all the pathogenesis that happens during infection, clinically it seems to be a very, it's a moment in time that's very early. It's sort of remote from the events of AIDS, and when people really get sick, it's way up here. CD4 counts are good, immunity is good. So why do we care? Some of you probably think that's a silly question, but I think it's a really, really important question, and I think we're still learning why. There is an important reason, of course, to do with transmission. More than any other phase of disease, acute HIV infection is a time that's associated with very high infectivity, as Dr. Collishman mentioned. The attack rate of an infection is the rate of HIV, of the incidence of disease among exposed individuals. And in acute HIV infection case series, where partners who have been exposed sexually to acute HIV infection, both gay men as well as heterosexual couples, in all of the case series that I've seen, the rates of acquisition among partners have been between 1 in 4 and 1 in 2. So the rate of acquisition after exposure to acute HIV infection is many, many times higher. This many times higher than one would expect based on the acquisition rates in, for instance, discordant couples studies, where it seems to be 1 in 200 coital acts or something like that. So why is that? I think there are a number of important reasons. One is that the per coital act infectivity, transmissibility is higher. It may be 6, 9, 20 times higher, depending on the type of act and the type of partnership. However, it's also higher, and this is both because of the high genital viral load, but I should emphasize is also because early viruses, which have just been successfully transmitted and have not yet undergone a lot of adaptive changes in their envelope structure, appear to be, some studies indicate, hundreds of times more infectious per virion than similar viruses from the same patient after the virus set point. So the reason I emphasize this is not academic, it's because it is not safe to assume that once the viral peak has passed, that the period of peak infectivity has passed. Patients may continue to be infectious for some time after peak viremia, and I think that's an important point. The other point about acute HIV infection transmission is that one of the reasons is not related to biological infectivity, but to the fact, which is a very simple fact, that the time that people's risk behavior, your risk behavior, my risk behavior, is episodic. When people leave home, when people, and sometimes people enter periods of high risk, and then they grow out of those periods of high risk. It goes up and down. People who are around the time of their acute infection are very likely to continue in their episodic period of highest risk activity. So it's important to consider that, and that the fact that there is more sexual activity among people who are acutely infected amplifies their importance in epidemic spread. The consequences of amplified transmission within networks where there is frequent partner change is that it is absolutely critical to be able to identify acute index cases. And it's critical for public health reasons, for two reasons. One is, of course, that we've already discussed that these partners down here who may be exposed to this acute index case are all at high risk. However, it's also important to realize that people with prevalent, established, non-acute HIV infection have very variable infectivity. Some people infect every partner. Other people infect no one. So if you have identified someone who has one of their partners, if this person is acute, one of their contacts is actively transmitting. So this person is another person whose partners are at high risk. So in order to abort transmission in the entire network, it's important to work not only on the index case, but also on the source patients. And these are can be generally thought of as active transmitters. I think that's a helpful way to think about it. And as I mentioned, the end of the epidemic is beginning to look a lot like the beginning of the epidemic. What do I mean by that, and why does it mean that acute infection is important? When HIV began, and there are very, very compelling data from early models of epidemic transmission from Jim Koopman and his colleagues, that demonstrated that in the initial spread of the epidemic, acute HIV infection dominated because of this higher transmission, even though it only lasted for a few weeks. It was so much more infectious that these new cases, who everyone they would come in contact with was susceptible, that these would dominate transmission. Absolutely. There were not enough chronically long-term infected patients around to begin to infect comparable numbers of patients. So all of the transmission in gay networks essentially was attributable in the first 4 or 5 years of the epidemic to acute infection. But over time, the number of chronically infected patients who were still off of therapy declined and clearly decreased the relative importance of acute transmission, to where people believe that in the early post-treatment era, around the 2000s in San Francisco or other cities like Montreal and so forth, the contribution of acute infection was probably somewhere less than half, but still a substantial proportion of transmission. As, however, we've grown toward a 90-90-90 type of world, we're currently in San Francisco, about 80% or 75% perhaps of HIV-positive individuals are both in care and suppressed on antiretroviral therapy. The number of, and those who are not suppressed are largely, who know their status, are largely having sex with other gay men through serosorting behaviors, seroadaptive behavior, or are using other strategies to avoid infection. Essentially, we have reverted to a situation where the majority of transmission is again happening among patients who do not know their status and does not, no longer predominantly involves patients who are being effectively managed in care. So in this type of situation, there is a chance that epidemics will decrease and will maintain low numbers. And we've seen this in San Francisco. There are plenty of data I could show you showing the decreases in cases in San Francisco. But the main point that I would drive home is that if this is going to be sustained, we need strategies to prevent the resurgence of outbreaks. And we are now needing to think of the epidemic in San Francisco the way that firefighters think about making sure that a fire, after it's been put out, is completely suppressed and does not come back. So putting out brush fires, identifying small epidemics, and so forth. Okay. What are the, that's more than you probably wanted to know about the public health benefits of acute HIV infection, detection and intervention. And I just should say that, of course, PrEP and other prevention strategies, HIV education, as well as antiretroviral therapy are all incredibly valuable in acute HIV cases and can be used for something you can think of as ring prevention strategies for acute infection. But turning to antiretroviral treatment, which is certainly a concern of ministries of health trying to make policies about acute infection management, as well as for individual clinicians. It is clear, and has been clear for many years, due to the conduct of multiple randomized clinical trials that have treated patients with early infections, post-seroconversion, usually treatment initiated sometime between 1 and 6 months after treatment, and sometimes interrupted, sometimes continued. But in all of these randomized trials, a theme has emerged, which is that patients tend to have better, more robust CD4 T-cell responses. They have, when their treatment is interrupted, they have improved viral control to the degree that their set points are lower by about a log, which is the type of effect you typically see with a good drug. So you can think of acute infection like 3TC. The patients actually do, on therapy, at least for the first 3 to 5 years at the beginning of treatment, have improved CD4 T-cell counts, if that's important. They have lower T-cell activation, and some studies have shown improved T-cell function, vaccine responses, et cetera. Recently, there's been a lot of discussion, particularly from results in the Thai trials, about the importance of lower levels of putative measures of the HIV reservoir, so viral RNA positive cells in PBMCs, HIV DNA levels in PBMCs, and some evidence in lymph nodes, all of which suggests that you may possibly be able to lower the HIV reservoir, prevent seeding of some of the HIV reservoir with very early treatment. If this is true, this would be important in the future for cure strategies. What you will notice looking at this list of things here is that none of this is exactly earth-shattering. These are not very large benefits. At least it's not clear how these would translate into differences in outcomes day to day or year to year for patients. Some people have thought that the changes that we will see in the benefits that we will see in acutely treated patients, we will only see when they reach the age of 60 or 70, and then we'll see they'll be much healthier. And I actually do think that that's likely to be true, but it's been largely a theoretical benefit of early treatment that has driven interest in this emergency treatment rather than clinical, meaningful clinical differences. And I am beginning to think that that may change, and one of the most important findings, I think, recently is from a study that in which I collaborated with Dr. Letterman as well, and some other of my colleagues in Peru. And we questioned whether or not, and the findings are a little bit surprising, as I'll show you. We questioned whether or not earlier HIV ART initiated during acute infection might actually prevent a HAND, which HIV-associated neurologic disorders, which Lish talked about the other day, and which you'll remember are very common, are improved but not completely reversed by ART initiated in chronic infection. There actually was reason to believe that it probably couldn't be improved by early treatment. And that comes from the largest prospective trial to measure neurocognitive outcomes ever. This was the START Insight trial that did extensive neurocognitive evaluations on 608 patients who were randomized at the time of early infection, having CD4s over 500, to either treatment or immediately or delayed treatment when their CD4 counts reached a lower level. And they found no effect. Everyone improved slowly while they were on treatment, but ultimately everyone reached a similar place, and they measured overall decrease. So there was this suggestion that early HIV infection, although something happens if you don't treat HIV infection, as long as you eventually initiated therapy, patients would end up doing just fine, doing just as well. But one of the criticisms of that study was that only a small minority of those early infection patients actually were acute. And if a lot of the early neurocognitive damage of HIV infection happened during acute infection, it would have been missed in that study. So the question whether or not earlier HIV treatment would prevent hand was not answered. So we proposed this study within the SABES cohort. This is a very interesting cohort, which was organized by Javier Lama and Ann Dewar in Lima, Peru, at the Impacta group. It was a large randomized trial of immediate versus delayed ART delayed by 6 months in patients with acute and recent infection. The cohort followed a 2,000-strong HIV-negative cohort with monthly HIV RNA and antibody testing, and defined patients who became positive during that follow-up as either acute, meaning very acute, they were antibody negative but RNA positive, or what they called recent infection, who sometimes were just a few days later than that acute group, of course, but were antibody positive at their monthly test. And had been negative on an HIV RNA test the previous time. What you see here is the consort diagram for this trial of 3,000 patients who were screened. 2,000 were both HIV negative and came back for monthly follow-up. Of those, about 10%, 215 individuals did seroconvert during follow-ups. They were able to identify 215 patients with acute and recent infection. About a third were acute, 2/3 in this still quite acute recent group, and they were randomized, stratified by acute and recent status into either immediate ART as soon as possible, usually within a week, or deferred ART, deferred by 6 more months. And as you can see here, these are the days from the estimated date of detectable viremia to cohort entry. You can see that the two treatment arms were very well balanced in terms of the distribution of times from infection, and that the vast majority of patients, there are a few outliers not shown on this diagram, but the vast majority of patients were between half a month and 2 months infected. Study procedures were antiretroviral therapy, which initially was treatment with Truvada and efavirenz, but later was changed to Stribild to incorporate integrase therapy into the trial, and that was changed for all patients. It was either immediate or delayed by 24 weeks. The neurologic substudy participants were a subset of these patients. Began slightly after the trial was already underway. Most patients did consent to this study. We measured both lumbar punctures at 0, 12, 24, 48, and 72 weeks, as well as detailed neuropsychological testing batteries. For those who are not familiar with these are extremely detailed neurocognitive testing sessions, which involve measurement of 8 separate domains of neurologic and cognitive functioning, some of which are shown here. Some of the most commonly affected areas are processing and fine motor in early HIV neurologic disorders. They were summarized as the total Z-score, which is a summary measure of one's total neurocognitive functioning. And very important to this study is that there were Peru-specific normative data that had been collected from HIV negative and positive individuals in an ACTG study that had recently been completed. So those were available for us and able to norm our data, which is something that was not able to be done in the START Insight trial, which was a multi-center trial. These are the results. In terms of the number of patients, we had a total of 85 patients out of the total of 215 who had the neurologic assessments done. 61 have data now complete through 48 weeks, and we expect approximately 75 of those to eventually make it to week 48, and we should have complete data to report at IAS this summer, and we're hoping to do that. There were no differences in terms of the overall patient characteristics, in terms of the duration of infection, as I showed you, CD4 count, the ART regimens were evenly distributed, and the total neurocognitive function Z-score was virtually identical in the two groups. The biggest and the most obvious things about the neurocognitive data considered over time, and we considered neurocognitive scores for each individual as the change from their baseline. And the reason for that is important to know, and that is that there are important training and practice effects with repeated neurocognitive testing. You give someone the same test 5 times, each time they do a little better. They learn how to do the tasks. And so it's expected that there is an increase over time. So we measure the change for each individual from their acute infection baseline over time. The total Z-score was similar, as I said, between groups, but it increased over time in both groups, as was expected. However, at week 48, there were clearly better neurocognitive performance overall in the immediate ART group compared to the deferred ART arm. And this was the hypothesis that we were testing, although one which most people did not expect that we would see. The change from baseline was higher in the immediate ART arm, and this was highly statistically significant. This is a graphical representation of that change, and you see here the p-value for, this is a two-sample t-test comparing the distribution of these, and here's another view of the data showing that there is a remarkable amount of variation in the data, and here at baseline, everyone has no change from baseline, right? But overall, everyone tended to increase over time, but by 48 weeks, there was a significant advantage to the group who had immediate ART versus later. Now, these are patients who, in the immediate ART arm, have had 48 weeks of ART. This group had 24 weeks of no ART and then 24 weeks of ART. So all of these patients have had 6 to 12 months of antiretroviral therapy. They are stable on and generally suppressed on antiretroviral therapy. And those who were treated during early acute infection have a significantly greater increase from their baseline measured over time. Now, I do want to focus our attention on this because I think I personally find this incredibly compelling. And the reason is, although if you look at it this way, you think this doesn't look so exciting, right? They're kind of overlapping, and there are some people in this group do better than people in this group. But the fact is that this is a mean difference of about almost 0.2 in total Z-score. And in some of the domains, such as fine motor and some of the processing speed measurements, it was even higher than that. Now, I've asked my neuro experts, such as Kevin Robertson at the University of North Carolina, how he would describe that sort of magnitude of change. So the question that someone like myself asks is, would you notice this this degree of change in someone? And he said, absolutely. And the example that he used was, if you were, you probably could notice a difference in someone who had declined between two visits by 0.15, 0.2 on their Z-score. If someone had a substantial decline in fine motor processing like this, if they were a mechanic, or if they were a musician, a guitarist, they might be able to play the guitar, but they might not be able still to play the guitar very well. This is the type of degree of brain dysfunction that has consequences for people's livelihood, for their self-concept, and I think is the type of thing we need to pay attention to. So this is early, it's only 48 weeks, but I think it's compelling, and leads me to think that we need to add this, at least preliminarily, to the list of benefits, and this, if this is confirmed in longer-term follow-up, potentially in other studies, I believe that the difference in neurocognitive functioning with, and potentially protection from brain damage with early antiretroviral therapy may be the most important benefit to very early treatment. So the first challenge you face in implementing strategies targeting acute HIV infection is how to identify early cases. And I'm going to speed through this, so forgive me after spending all that time on the brain. I'm going to, you need your brains to pay attention because I'm going to go quickly through this. So the most important thing to identifying acute infection is not using HIV RNA tests or using fourth-generation tests instead of rapid tests. It's the frequency of HIV testing among patients at risk. If patients are engaged in high-risk activity, if they are a core population at high risk of HIV, you need to be encouraging them to test 3 to 6 monthly in whatever way you can. Someone whose test converts on an antibody test within 3 months is a very acutely infected patient and would have fit in the profile of someone who would benefit from the study I just showed you. Using HIV tests that are able to identify antibody-negative HIV infections, such as fourth-generation antigen-antibody combo tests or HIV RNA tests, are, however, an important adjunct to frequent testing. In San Francisco currently, for instance, we have 22% of all of our testers who we diagnose are antibody negative. And this is because we do have already such frequent HIV testing in our MSM, our gay population. The clinical systems for recognizing acute HIV infection that are the biggest barriers to HIV being recognized are not the ones you would necessarily think. One extremely important issue is that when discrepant or indeterminate results turn up, when someone has a negative antibody test and a positive fourth-generation test, for instance, a lot of times that is something that's handled very slowly and takes sometimes weeks or months to resolve the person's HIV status. That's a problem. And is something that the availability of rapid RNA testing or reflex RNA testing right away could certainly help with. Clinicians are often not alert to the possible presence of acute retroviral syndromes because they rarely know that their patients are at risk when they come into ambulatory care settings, such as emergency departments or urgent care clinics. And because usually most general medical clinicians have never diagnosed and would not recognize an acute infection because they always, when they see it, think that it's the flu or it's mono or Epstein-Barr virus infection, or they think it's Zika. So Routine assessment and documentation of exposure when patients are positive is often not done. So the fact that someone was tested and negative 3 months ago, 6 months ago, a year ago, usually never makes it into the medical record. So patients who you have all the information usually don't still get recognized as being acutely infected, at least at the time that they enter care. And one of the things that is a potentially very useful adjunct to all of this, once all of these other things are in place, is that there's another type of information that is rarely recognized, and that's in part because we haven't yet figured out how exactly to interpret it, although we are close to being able to publish some of that data, is that there's information from some of the new routine diagnostic tests that actually can work as testing for recent infection. It can actually inform estimates of individual level timing and tell you if someone is either infected in the last 2 months, 3, 4 months, or 10 months ago. These are the types of tests that we have. The time at which they become positive starts about 10 days into infection. 25 days here you see before Western blot full positivity with the RNA tests, and then over time all these other tests will initially become positive. However, positive is not positive. Positive sometimes is a very weak response, sometimes is very high. The most obvious of these is the viral load. The viral load goes up reliably during early infection. And in fact, if someone is antibody negative, we've shown that you can actually use the viral load level. If it's high, you can estimate that they're infected weeks later than if it's low. So this is actually a very reliable marker in antibody negative samples of when somebody is infected. Other thing that's interesting is that many of the new fourth generation antigen antibody assays, all of the fourth generation tests that you all are familiar with as screening tests, some of them use chemiluminescent readouts which have a very, very broad dynamic range and actually can quantitate the amount of virus in the antibody negative state and then the amount of antibody in antibody positive individuals. And the consequence is that, and draw your attention to, these are HIV positive, these are all positive tests in the gray from a cohort study that enrolled patients who were testing for HIV at STD clinics in San Francisco. These are gay men at an STD clinic. These are the non-acute HIV antibody positive specimens here. These are the RNA positive antibody negative specimens here, also gray, and in gray here are the false positive specimens. These are the ones that turned out to be RNA negative when they were tested. They were antibody negative and RNA negative and did not convert in follow-up. So these patients, you'll notice, all had very low readings here on the y-axis, which here is the signal to cutoff ratio. So this is the reading that the lab gets. They typically don't report, but this information is available to labs, and at least with the Architect assay, which is an Abbott assay as it's sold in the US, is highly predictive of whether someone is likely to be a false positive. This is actually the most important use of those data because in the setting, certainly of an acute infection, when patients have a antibody negative result and you're wondering whether they are a false positive or an acute infection, it's important to know that most of the acute infections will actually have very high readings above this level of 15 or 20. And if it's below 15 or 20, you are not sure whether it could be a false positive or one of these other acutes. The other point I want to point out on this slide, so this is a very useful piece of information to have in the day that you get the result, and can guide initial clinical decisions. Indeed, we use this at our center, and other cities are also using this information that use this test to decide whether to initiate treatment even before an RNA value is back. The other piece that's interesting here is the black dots. I haven't mentioned, these are from testing at San Francisco General Hospital in our various inpatient and clinic services. And what you notice is that in medical settings, such as many of you will know, where there are fewer high-risk patients in the population and people are not testing every 3 to 6 months, the low values are virtually always false positive because there are no acute infections in that population, or very few. Uh-oh, did I time out? Could be. Oh, here we go. Okay. I broke it. No, I didn't break it. Yay. Okay. Un momento. Okay. So this is data, actually, if you're interested, if you incorporate, as I mentioned, the viral load can be used to date infections and predict the timing of infections. These are a data set of specimens that were collected among seroconverters where the date of infection was known within 3 days of because they were followed as plasma donors. They were donating blood very frequently, and so their date of converting to RNA positivity was known within 3 days. And within this group, the accuracy of a classical, what we call the FEBIG staging of acute HIV infection here. These are FEBIG stages 1, 2, 3, and 4. We compared then with our new estimates using the blood viral load. And this was a validation data set based on the model which was developed on separate data, and it looks really good. Here's the intraclass correlation of 0.8, indicating extremely good correlation. And what this indicates is that if you are doing estimation based on, if you're doing analyses such as looking at cure interventions that rely on differences on the order of weeks in the timing of initiation of treatment in acute infection. And so an example would be all of the data that are presented by the Thai cohort in their treatment cohort. It's critical, I think, to use this type of estimate. Did I do that? I think I might be turning it off. I think I'm clicking the wrong button. So, So, one last thing on the diagnostic tests. I mentioned that there are several different types of diagnostic tests. So their viral load information, right, is valuable in understanding where someone is in acute infection. The signal cutoff ratio on the 4th generation assays I mentioned can be used to decide whether someone is a false positive or may have a very high signal cutoff ratio and likely true positive. But what's shown here is something else. For those of you who do diagnostic testing, you're probably familiar with the DPP assays, the immunoblot. And our research into this testing, this type of assay, started actually in Caxias do Sul, where Leonardo Mota, who was the head of the laboratory at the University of Caxias do Sul, was looking at our seroconversion cohort specimens and started measuring the band intensities that were coming out on the reader for the DPP assay, which is a rapid test and gives you bands that look like the bands on a pregnancy test. It's a lateral flow test strip, just like many other rapid tests. But the band intensities are measured and given as a quantitative reading by the reader. And so we developed a scoring system and looked at the changes in those over time, and they went up reliably over time and never seemed to bounce around much. They really went up pretty consistently. So we were excited and wondered whether this could be used like some of the lag assay from the CDC and so forth. This assay, virtually this exact same assay is sold in the US as, by Biorad as something called the Genius confirmatory assay. And here is one piece of data using specimens that were collected both in the US and in Africa and by Esper's group here, and based on the concept that was developed by Leonardo Motta. And what you see is that the Genius index, which is a summary of the band intensities of 3 of the 4 bands on this rapid test assay, go up reliably over time. And in fact, you can use these type of data if you know, I'm afraid I'm going to turn this thing off again, but okay, good. Whew. If you know someone's testing history, and here is an example of a computer simulation sampling those individual data curves. If you know someone's testing history and what the prior probabilities of infection dates are, in this case, this is a scenario where the patient is tested negative 3 months ago, 90 days ago, right? So their average time of infection would be here, and there's a uniform distribution of times. This shaded area is the interquartile range of this prior distribution of infection times for this individual. And what's shown here is, as the test for recent infection value goes up, and this is actually data for the Architect signal cutoff, believe it or not, as it goes up over time, you actually are able to very nicely narrow the likely posterior distribution of infection times that are associated with any given value on that test. So, and this is just to demonstrate, first of all, how well it does help you squish down and enhance the precision of your estimation of when someone was infected, from just saying, it was sometime in the last 90 days, to no, it was probably in here. And it gives you an indication that it's actually similar to the degree of precision that you get in Fiebig testing. And this is just the plot I showed you in the previous slide, overlaid on the same time scale. So, a lot of that is sort of future, coming soon to a laboratory near you. Most of the indices and data that are potentially useful in acute infection case finding are not yet available. But we are trying with WHO and the diagnostic companies, the US FDA and the CE, and potentially the Ministry of Health here to try and make those data available to clinicians, because we think they would be very useful. One of the ways that they would be used, obviously, is initiating early antiretroviral therapy. And I know I'm going a little bit long, but I want to share these data with you. They're so exciting. And so the question is, if we know that ART benefits everyone, but particularly that the benefits that ART gives in acute infection depend on timing, on rapid delivery of treatment, the question is, can we give it right away? Is there any reason that we don't treat HIV like we treat syphilis, where someone's diagnosed and they get treated and they leave the clinic on treatment? Why can't we do that? The reason we can't do that, we thought, is because initiating patients on antiretroviral therapy is a lifelong project. It's very, very difficult, and it involves a number of critical steps. You can't skip any of these steps. Patients need to be diagnosed, they need to be counseled, you need to handhold them through their understanding their status, they need to be referred to a clinic, they need to be scheduled in a clinic, they need to have health insurance arranged, housing, substance use, mental health issues addressed, they need to have HIV education so they understand what's going on, and they need to have safety labs drawn at the beginning of their treatment. At some point, they then have a primary care physician assigned and a visit scheduled. They come back, they are seen by that patient, by that physician who hopefully has their labs in hand, determines whether or not to treat the patient, what to treat them with, at some point prescribes treatment, and eventually, months later, the patient becomes virally suppressed. This kind of, yeah, okay, you can see it. So the time at which these things happened in San Francisco is antiretroviral treatment, which is started here in the green bar, typically has taken about 4 months from the time someone's diagnosed for patients to get in. And a lot of that time is taken up by these various steps here. There's a long wait before they see their primary care physician and then have go through all the steps to come back and eventually get treatment started. And then eventually they get suppressed, and the average was about 218 days before 2009 when we used CD4 criteria, similar to what were recently in place also in Brazil. And after 2010, when universal ART guidelines were promulgated, that was reduced to about 40 days, a little over a month, to get on antiretroviral therapy after an initial referral was made to the clinic. So we asked whether we could collapse that, and we developed something in part based on our experience with spending all day with patients in clinical trials, knowing that we could do it if we spent a lot of effort and a lot of time doing it. And we decided to try it, initially with acute infection patients, and then later, as I'll explain, with all of our patients, and now all patients in San Francisco. And the RAPID program is shown here. What happens in the RAPID approach is a little bit different than this whole thing. What happens, first of all, is that all of these processes, the lab testing, the counseling, the insurance registration, all that all starts on the same day, but it doesn't finish on the same day. They're not begun in a series. They're begun all at the same time. It's an intensive visit. It takes several people who have flexible time to see the patient on that day. What also happens then, ART is begun, labs are drawn, sometimes simultaneously, sometimes the labs are not available when the patient leaves still on treatment, and they have telephone follow-up. The role of the primary care physician changes radically, at least at the first visit. Physicians now meet their patients for the first time on treatment that was started by the RAPID team. And their job becomes managing the initial treatment rather than prescribing it, selecting it. They get to choose whether to continue it, whether to change it. The aim of our study was not only to look at the feasibility, but also to look at safety of the approach. For reasons I'll explain, it was extended from acute infection patients to all patients by the middle of the study in 2015. These are the intervention components, some of which I already mentioned. We actually we had some funds to facilitate transport of patients who needed taxi vouchers to get to the clinic, who were newly diagnosed. We had flexible scheduling. We had 1 or 2 providers who were always on call. We had a multidisciplinary team. ART regimens were pre-selected. We had a committee that was established and that meets regularly across the city of HIV treatment experts who decide which regimens should be approved, and that's based both on new safety and efficacy data as well as patterns of transmitted drug resistance, which change over time. This is a critical piece of our program, is that we provided antiretroviral therapy as 5-day at a time starter packs of medication. So this circumvented the need for patients to have their insurance cards all settled and to be registered with the pharmacy and so forth. And they could also leave the clinic on treatment. And indeed, we recommended and typically had the first dose given in the clinic by the treatment team. These are the characteristics of our patients. I point you to the fact that these are largely male patients, largely non-white. A large proportion, about a third of them were homeless, and all of them were uninsured. So this is the type of population we have. I don't want you to think, because this is San Francisco, that this is a very well, resourced clinic and easy, rich population. And so these are very challenging patients to treat. And indeed, overall, about 40% were acutely infected. There were more of those in the group who received the rapid intervention, the 39 patients, when compared with our control group of patients who were treated by other clinicians not involved in the program during the period of the study. They were otherwise balanced by CD4 count at entry, and the viral loads were a little bit higher, as is expected with acute infection, being one of the initial criteria. These are the regimens that were used, predominantly integrase-based regimens based on low transmitted resistance to integrase inhibitors in our population, and that's what you see there. Overall, ART uptake was remarkable in the rapid group. I'll show you it was not only high, but it was fast, and there were no excess transfers of care. Patients did have a slight excess of changes in ART regimens in the rapid group who started the same day versus those who started according to the standard of care. However, those were virtually all due to simplification and not due to toxicities. There was no, there was a large prevalence of transmitted drug resistance, predominantly to non-nucleoside reverse transcriptase inhibitors. The main point of this is probably best summarized by this slide, and that is that when you offer same-day treatment to patients, they want it. They take it. So this is the proportion of patients who were treated on the same day that they reached the clinic. And you can see some people were already beginning to uptake this approach, even among patients who were not in the intervention. This is in our control group. But patients within a week were essentially all taking antiretroviral therapy, and 90% of them on the day that it was offered. Patients loved leaving on treatment. They also suppressed much quicker, and indeed, so here's a Kaplan-Meier plot showing the rapid participants versus patients in the universal treatment arm, as well as a historical group of patients from the CD4-guided ART era. The differences between the rate of viral suppression here and in historical control groups was highly significant. And the time was reduced from an overall of about 4 months in the universal treatment era, and for universally treated patients to under 2 months, 1.8 months in the rapid cohort to viral suppression. So less than 2 months from initial registration at or referral to the clinic, the phone call to viral suppression. The reason I'm about ready to wrap up, but one of the things that is that I want to communicate to you, if I were to communicate anything, is how important same-day treatment has become for us. And when I say us, I mean most of the clinicians in San Francisco. San Francisco has adopted same-day treatment as a Department of Health mandated strategy. It is one of the 3 main strategies that are what we call the Getting to Zero Consortium in San Francisco currently uses to fight AIDS stigma, AIDS incidence, and AIDS deaths. And I mention the stigma, which is one of the goals of our Getting to Zero effort, because it's that is the most important effect. The first patient that I treated with same-day treatment, same-day observed treatment in this protocol was a young Latino man. He was a gay man who is probably 19, and he told me he was in tears when we first met. These visits take several hours, but when I first met him, as he was sitting with the social worker and he was talking to me about his risk exposures and so forth, he was in tears, he was in a puddle. And when I asked him what was most upsetting, he said it was because he was worried about his mother. He didn't know how he was going to tell his mother. His mother was the most important support person for him. When he finished the visit, he had been through a lot, and I was waiting to see him, and I met him, and he took his pill, and then he got up, he bounced up, and he had a big smile on his face, and he looked like a totally different person. And I said, "Are you okay? Are you sure, everything is okay?" Because you worry about, he just got told that day that he was HIV positive, and here he's like, looks like he's ready to dance or something. And he said, "Oh, I'm okay, doctor." He said, it's okay because I can tell my mom now, because it's not that I'm HIV positive, but I'm on treatment, I have a doctor, I'm taking care of it, it's all set, you don't have to worry about it. So the first day that he's HIV positive, he already knows, feels comfortable, is receiving treatment, feels like he's in control. So that it changes the whole dynamic of that first period. It's not a period of anxiety, it's not a period of waiting to start treatment. It's not a period of feeling contaminated. You're actually feeling like you're taking control, you're doing something, you have your pills, you know you can take them. It's a very powerful thing. And it has, within a year and a half of this pilot project, we had already decided to change our policy completely at San Francisco General, and within a few months of that, it became citywide policy. So this is, I think, a dramatic and a really exciting story. These are the key features that I think people need to think about in implementing this kind of system. It's critical that there be a single point of contact for people to refer patients to, so that patients from numerous testing sites who want to refer a patient for immediate treatment, everybody needs to know that number, and there needs to be always somebody answering that number. You need a multidisciplinary team, social workers, nurses and clinicians, MDs, and you need to be able to provide for not just the medication, but also to pay for the lab tests and so forth. So there are some administrative hurdles that need to be thought of. Clinicians often say, aren't we already doing this? Because they say, well, I treat everyone. But it's not you. If you're a clinician and you're doubting, you're a skeptic, and you think, I already do this, I already treat all my patients. No, you don't, because they don't get to you for 3 or 4 months until after they're diagnosed in most cases. You may prescribe medication on that first visit, but the challenge is to get them from the positive test result in front of a doctor on that same day, and a doctor who's willing to treat. So it's a new world. This is Dion Jones, my hero, who was our nurse, our social worker, Sandra, Sousa Coffey, and Clarissa, who's wonderful. And this is Oliver, who's leading the effort to take it citywide. And I'd like to really thank everyone, especially Esper, incredible conference, and a fabulous colleague, and the greatest acute infection researcher in Brazil, for sure, and all these folks, including my great colleagues who originated a lot of my interest in this area at the University of Caxias do Sul, including Maclean, who's here. So thank you all very much.